Hello and welcome back to my channel. Today we are talking about a very important topic, which is brain tumor. Every year, more than 30,000 people get diagnosed with brain tumors in India. And the unfortunate thing is that more than 20% of these are in children. And doctors believe that this number might not even show the true picture. Many people are out there who might not even be getting diagnosed. So I wanted to learn more about brain tumors and what can we do about them. So I've come to Apollo Hospital in Delhi to speak to one of the leading neurosurgeons in the country, Dr. Gaurav Tyagi. Dr. Tyagi, thank you for joining in and
Hello.
taking out the time. How are you?
I'm good. It's a pleasure to be here. Thank you.
Thank you. So you are a neurosurgeon. You are specialized in minimally invasive skull-based surgery.
Yeah.
And neuroradiosurgery.
Yes.
So what is that? What is it that you do exactly?
So we treat all kinds of brain tumors, and we try to do those with a minimal invasive way so that we create the smallest amount of scar and give like least invasive procedures to the patient. And also we treat the brain tumors of the skull base, which are difficult areas to reach. And of a lot of tumors we can go and treat through the nose. And instead of creating a scar on the forehead or cutting the bone, and we go to the nose and treat the tumor, especially like pituitary adenomas, if you know, craniopharyngiomas, those can be treated through the nose.
So for the audience to understand, I'm going to show some graphics here
Yeah.
later. But when you say you'll go through the nose, the level of the brain is sort of above the nose. So if you're going in from here,
So,
you're reaching the pituitary and the base of the
yeah,
skull
yeah. So
directly.
we're going to reach the base of the skull through nose, and
Right.
it's almost like the center of the whole brain. If you see that pituitary gland is there,
Right.
and from there we can reach above in the area. So you are creating very small footprint on the whole. It's just going through natural orifices. So we try to do that.
As opposed to, say, opening the skull and going in.
Yeah, we do opening the skull as well.
Yeah.
For most cases, but we try to be as cosmetically good for that, and also doing a maximal safe resection. That is the concept of any neurosurgical procedure for brain tumors.
Right. How big of a problem is brain tumor? How many brain tumor cases do you see?
So, like you said, brain tumors, almost 5 to 10 people per lakh patients, per lakh people in India have the problem of brain tumors. And in our clinic, we see somewhere, say, around 10 cases every day for brain tumors, either admitted in the hospital or in the clinic or on online consult. So we get in touch with almost 10 patients with brain tumors every day.
Wow.
And so we offer them surgery, we offer them radiosurgery, which we'll discuss, and we offer them radiation after tumor resection.
Yeah. Like an emergency,
Yeah.
it's a big medical problem. The burden of brain tumor
the
is
burden of brain tumors on the society,
Yeah.
for the social as well as economic burden of the disease is a lot, and it is increasing.
It's increasing from a few decades back. You
Yeah,
think
it's increasing from the few decades back because there are improvement, of course, in the field of radiology. So we have better investigation procedures. We have more clinics and more doctors now who the patients can reach out to.
Right.
And so a lot of patients, and especially also people, are living longer now. So with old age, there are a lot of tumors which occur in elderly people, and those get detected also because of early detection of tumor also is happening.
Right. So cancer is scary no matter where you get it in the body. What makes brain tumors any different from, say, a tumor in the liver or in the gut? Are there special challenges for brain tumors that other cancers don't face?
So the problem with brain tumors is that the surrounding area of the tumor, like if you say if you have a tumor in the intestine, you can remove a segment of intestine and you can resuture that.
Right.
But in the brain, every area of the brain has got some specialized function. So you just can't go around and just remove the tumor, damaging the surrounding area. So we have to be very, very careful on how we treat not just the tumor but the whole brain. So we have to take out the tumor piecemeal and not like a single whole thing.
Right.
And we have to remain within the tumor. We just reduce it, make it smaller, take it out. Then and the orifices, the approaches to the brain also has to be taken care where you are entering, because you are always surrounded by some important nerves, some important blood vessels, some important neurons of the brain. So every area is important.
I remember there was this case when I was a resident where it was a 45-year-old lady, and the only complaint was that she would get very irritated with her husband for the last 3 months. And everybody in the family thought that, oh, it's just that the husband is annoying her.
Yeah.
But the husband brought the wife saying that, no, she would never get annoyed with me before. It's not my fault. Check her. And we did a scan and there was a frontal lobe tumor.
Yeah, so the problem with frontal lobe tumors are they generally present with sometimes behavior and personality changes, memory disturbances. You may have like the or your patient may become suddenly dull, socially recluse. You may have some calculation deficits, and all those things are there. So you have some sort of cognitive dysfunction rather than showing up with headache and getting any limb deficit or anything.
Right.
So that changes in behavior, changes in personality. Sometimes you see there is an underlying brain tumor. So that's
Yeah.
an interesting presentation.
Correct. So people also need to be aware of this, that sometimes brain tumors can present in very subtle ways, and any change in behavior should be looked at.
Something which is out of the something which is like out of ordinary, the behavior is significantly worse and progressively going in one direction.
Right.
So I think that you have to see your neurologist or your neurosurgeon. But most brain tumors, they present with some mass effect on the brain and cause headache. You may have blurring of vision. You may have vomiting, nausea with the headache, especially vomiting getting early morning. And then you may have giddiness with your tumor. And there tumors also located in specific areas of the brain, like we're discussing with the frontal lobe. So if there is a tumor which is close to the, say, your optic nerves, which are the nerves to the eyes, you may have decreased vision. You may have altered smell. You may have decreased hearing with tumors of vestibular nerve, the eighth nerve, as we were discussing. And you may have facial weakness. You may have difficulty swallowing, walking imbalances, or weakness of a limb. So those are the symptoms of how brain tumors present. But most of them have some sort of headache, giddiness, vision impairment.
Right. This is an interesting point, because in my neurology clinic, a lot of patients come with headache. And there is a general fear that what if it's brain tumor? And we are told that not every headache needs a scan unless there are red flags. So what you are describing are actually all the red flags that come along with headache. And I would assume that if anybody has a new onset headache or headache that they've never had before, then it is a red flag and they should get imaged.
So mostly this is called when the pressure inside the brain increases. So the headache will be progressive. It will involve most part of your brain, like it will be holocranial, as we say. It will involve your whole brain. And then it will be not relieving with your simple rest, medication or anything. Then you may have blurring of vision with headache, which is very, very important sign. And if you are having giddiness, and if you are having vomiting with your headache, so that is like early morning, you get up, you have nausea and you get vomiting, and your vomiting is relieving your headache. So those are the signs of raised pressure inside the brain, that something is wrong and you need to see your neurologist, neurosurgeon immediately.
That's a very important point, and I'll make sure that we highlight these points for public awareness. I wanted to ask you about treatment of brain tumors, and I know that now in India there are more and more places where brain tumor is getting treated at, you can say, global standards. What has changed in the treatment of brain tumor in the last decade or so?
So the treatment of brain tumor starts with first investigation, right? So there have been remarkable changes in how we have moved from doing only X-rays and then going to CT scan. Now we have MRI, which have gone to 3 Tesla, 7 Tesla, improving. And we have a lot of things associated with MRI where we do functional mapping of the brain, and we see how the tumor is related to some areas of the brain which are important for function of like a limb or your speech. So we do MRI for every brain tumor patients, and MRI just not only help us to diagnose the lesion, but also help us to plan how to approach it. And after MRI, we plan the surgery either through the scalp, through the brain, or we go through the nose, and how to be taken out. How do we go for complete tumor removal, or we do partial resection? That we plan according to the type of tumor. And so we use microscope in most of the cases while doing surgery, except while we are doing through the nose, we use an endoscope, but otherwise we use a microscope. And we see in the microscope and we operate like this. So it's like you're playing with your headset or playing a game.
Right.
So a microscope is used for most of the cases, and we operate on your finger levels, so
Yeah.
or your wrist. So it's not like you're
Your
opening the
whole
abdomen
arm.
and taking out tumors like this.
Yeah.
And with now improvement in the concepts of micro neurosurgery, with imaging, with microscopes, with endoscopes, we use intraoperative navigation, which are which help us to know in real time where exactly we as compared to the pre-op MRIs, and what exactly
Right.
are the lesion which are to be removed, what is to be spared.
Right.
And we can use angiographies within while operating intraop with the
In real
micro
time
in real
to see
time.
the blood
Yeah,
vessels.
to see the blood vessels, as well as to see the margins of the tumor. So those
Right.
areas will take, like we use fluorescent, we use ALA. So these are different dyes which can be used
Yeah.
intraoperative for tumor resection.
Very important point. So that people get context, it's very important to remove the margins of the tumor, because if it is a
So
malignant tumor,
it
it can come back.
yeah, we try to do that, but it's not like oncology principles elsewhere in the body where you need margin, because the surrounding areas are very important. So they may have
Right.
some functional deficit if we go removing too much of surrounding brain tissue.
Right.
So in those cases we may have to compromise of not removing that, but we do maximal safe resection.
Right.
That means you go as much as the tumor as possible, as much of the tumor which is obviously visible.
Right.
And if we use these adjuncts, as I said, to remove more of the tumor, but not giving deficits to the patient. So that
Right.
thing has to be balanced with.
And this is the challenge of
Yeah.
neurosurgery, which other organs might not face as
Yes.
much, because every centimeter of
Yeah.
brain tissue
Every
matters.
millimeter brain tissue. Yeah.
I wanted to ask you about global versus Indian standards, because there might be this belief that the treatment of such complex problems would be better outside. But is that the case? Has India come
So
up to global standards?
if you see some centers like the one we are sitting now, or the one we and you are trained
Yes.
in places like Niman, Sanjay Gandhi PGI, AIMS, all these
Yes.
places, these standards are almost as good as in any country in the West.
Okay.
We have all the equipments. We have doctors who are trained in West, in here, with lots of experience and are doing well. But there's a big disparity. These are available in all the metro cities and all the good government institutions, but it's not uniform across the country. So that is the one big challenge that we are facing. That's why we are all overloaded with work in metros and other places. So that it has not percolated down to all the centers. It's becoming better now with more regional centers coming up. But if you see in areas in, say, in Delhi, in Bombay, in Bangalore, we have the treatment. We have centers of excellence which are as good as anywhere in the West.
Right.
And we are treating patients at a significantly less cost to
Right.
the patient. Yeah.
That was going to be my next question, actually, which is, what is the cost of something like a brain tumor surgery in India? Because I know that a lot of people would have that as a significant challenge in getting the right care. So could you give the audience some kind of understanding about the costs?
So it's variable. It depends
Of
on where
course.
you are getting it done. If there are good government centers where you can get it done almost free, because there are not a lot of schemes are there from the government which has been given for poor people. And if you come to a hospital, for a corporate hospital, I say average it can be brain tumor surgery can be done, say, between somewhere 3 lakh to 10 lakh rupees.
Yeah.
And if you compare these to the West, like a surgery, similar surgery which is done in US will be hundreds of $1,000, $100,000.
Dollars.
Yeah, so it is significantly cheaper compared to any Western country in India with the same standards.
And that must mean that there will be people there who have, say, an insurance problem, or who are on a long waiting list.
Yeah.
I'm sure there must be a lot of people coming from the West
Yeah.
to India to get treatment.
So there are people coming from West because of long waiting time, especially like a country like UK. You've seen the
Yes.
NHS is such a big problem.
Absolutely.
And mostly like Indians settle there. They want to come back here and get the surgery done because they know they trust the healthcare system here. And the cost is also a benefit for them. Like, it's easy, the whole thing coming here, flying into India, visiting Taj Mahal, getting surgery done and going back. It's cheaper than getting it operated in private in UK.
Yeah.
And but there are patients in countries where the healthcare is not as good. Like, you may like to go in like the erstwhile CIS countries, or the poorer part of Middle East
Right.
and African countries. So those countries, patients have it find it easier to come to India
Right.
compared to going to anywhere in Europe or US in amounts of cost or in amount of availability of specialists.
Right.
So those are the countries who are coming in numbers to all major cities, and it's India is one of the big healthcare tourism destinations.
Amazing. Speaking of newer advances, I know that there is a new radiotherapy treatment
Yeah.
option that's come up called ZapX.
Yes.
Can you tell me what ZapX is and why is it so revolutionary?
Yeah. So before ZapX, I just want to tell you about radiosurgery, right?
Sure.
So it's so there is radiotherapy and radiosurgery. So what we do after any tumor removal, we send the patient sometimes if they need to radiotherapy, and therapy is given on small fractions of radiation given over a period of like 28 to 30 days. So you go
Right.
every day, you get your radiation done.
Right.
What radiosurgery does is give very high doses of radiation in a single session. So it's the timing of a surgery, the precision of a surgery, but the dose is very high. So that dose you give to only the tumor, so there is less damage to the surrounding tissue, and you give it in like a single session.
So
So
those are
that's
not
what,
in cycles.
yeah, that's why it is called radiosurgery,
Okay.
and the one which is given over a long period is called radiotherapy. So,
Got it.
like for example, for any brain tumor, we give around 60 gray over a period of 30 days. So
Okay.
that's almost around 2 gray
2
per day.
grays per cycle.
So
Yeah.
in radiosurgery, we give 15 gray, 18 gray, 20 gray in a single shot.
Oh.
And the machine has to be precise so that there is no surrounding damage to the normal areas of the brain.
Right.
That's why we have dedicated machines for intracranial radiosurgery.
Right.
So ZAP is one of the machines, like Gamma Knife is one.
Correct. So Gamma Knife was the one that came first.
Yeah.
And that has, I think, cobalt.
Yeah. So Gamma Knife is been there for almost 50 years, and the concept was initiated in Sweden 1950s and 60s, and that machine is considered almost the gold standard for radiosurgery, and was the only dedicated radiosurgery machine for brain.
Right.
So, but it uses radioactive cobalt, which is a source for handling of it, for making that we have to create a special bunkers where this machine can be kept, because of course radioactive isotopes, you have to take extra care for that, and that has to be replaced after every 5 to 7 years because it constantly decays.
Right.
What ZAP does, it uses a LINEC, which is an X-ray generator, and it uses X-ray photon rays to give that precise radiation.
Okay.
So we have the physics of Gamma Knife, but no cobalt. So we
the
use the
effect
X-ray.
is the same.
Yeah. So physics-wise, it is the effect is as good as Gamma Knife. There is no the very sharp beams, so that surrounding tissue doesn't get the same amount of radiation which we are giving it to the tumor.
Interesting. I have a physics question, which is, if you are, say, I imagine it like a laser.
Yeah.
And so that laser is going into your brain. At what point, how do you control the depth?
So we use a preoperative MRI and CT.
Okay.
So those are fused together, and we mark the tumor.
Right.
And we put it in the machine, so the machine knows that where exactly the beam has to stop, where the energy has to be transferred. Okay. So it comes from all angles. So it goes one shot from here, one shot from here, one shot from here. So multiple shots, all together cumulative dose will be that. Oh. And we also measure the exit dose continuously, how much is coming out of the head, to make sure that everything is in place and only that tumor in the center is getting. So this is called stereotaxy. It is knowing in 3 dimension your localization of your tumor. Right. So the complete word is stereotactic radiosurgery, SRS. That is the technique here.
Incredible. Just imagining it, I feel this is so technically advanced. Yeah. And doing this will reduce the size of the tumor. And even if, say, you want to subject the patient to an actual surgery, this might make that task easier.
Yeah. So what radiosurgery does is alter the DNA of the like radiation induced changes in the DNA of the tumor cells.
Right.
So they stop replicating and they eventually reduce in size. So body's immune system take over. Right. So the tumor from the day we give radiosurgery, in most cases stop growing from that moment on, and slowly over a period of time it dissolves away and goes down.
Got it.
So how radiosurgery is beneficial? It is not for all brain tumors. Like the most common tumor, as we were discussing, is glioma.
Yes.
And it is not, radiosurgery is not the primary treatment for glioma. We have to do surgery first,
Okay.
then do radiotherapy. If there are recurrences, give radiosurgery. But there are almost 50% of tumors in the brain are benign, and so there are meningiomas, vestibular schwannomas, pituitary adenomas. So sometimes small incidentally detected tumors, which you have had a scan done for, say you have a trivial fall or a headache, and you did a scan and you saw there is a small tumor. Small, I mean less than 3 centimeter.
Right.
So you just can avoid going for like complete surgery, invasive procedure to remove that. It may be in a deeper location in the brain, and you avoid damaging the surrounding tissue in a part while undergoing surgery. So we can give radiosurgery to that. It's a daycare procedure. You come inside, get it done like an MRI, just go inside the machine, come out. Treatment time is around 30 minutes to 1.5 hour. And you can just get it done in a day's time.
That is actually incredible. Out of curiosity, DNETs, which is the neuroectodermal tumors, are they amenable for this?
DNET, the primary tumor, if mostly they present with epilepsy, they cause seizures.
Yes.
So in cases of DNET, we would like to do, if they are not, the seizures are not controlled and the lesions are growing, surgery is the primary treatment. Right. But for salvage therapy, like for partially resected tumors, or in those cases, radiosurgery can be given.
I think this is just important for people to know, because then they at least know that there are options available. Because I feel that a lot of people, once they get a diagnosis of something like a brain tumor, they immediately feel that that's it. There's nothing that can be done. So I feel this conversation is helpful from that respect. So now that we have spoken about ZapX so much, I'm curious to see the machine. So can we take a look?
Yes, sure, we can go. Yeah.
So that was a very interesting setup. What are the cases that are now possible to treat, which wasn't possible before?
So there was an interesting case. Like, it wasn't brain tumor, but it was an AVM inside the brainstem in the medulla. So
AVM is arteriovenous malformation.
Arteriovenous malformation. So it's a small malformation of blood vessels in the brain,
right?
And it can rupture and cause bleeding.
Okay.
And it was in a brainstem, a very treacherous location, very close to all your areas of where the control of your heart and your breathing and everything in medulla.
Right.
And it was very small. It was just 1.5 centimeter, but it caused a rupture inside the brainstem, and that lady survived that. She was a young girl, and she came to us after 2 months after the rupture, and so that it doesn't rupture again, we plan to do radiosurgery for it. And treating that surgically or by endovascular treatment, like going through the blood vessels and blocking it, wasn't possible because of the location and surrounding important blood vessels. So we did radiosurgery to that. And also it was a challenging case because we cannot give more dose to that area, because in brainstem all the neurons are very tightly packed in a very small area.
Correct. So even if you were to give it at a larger area, you will damage important centers around.
So radiation may cause damage to the surrounding tissue. So every area is important, so that very thin strip of AVM had to be planned, and then we run a lot of stimulations, and we made sure that we are very, very precise. And with this machine, with the precision and the versatility, we were able to do that case. So that was an interesting case.
Yeah. So this is interesting because it opens up so many new avenues of
Yes.
treatment,
Yeah.
which earlier it wasn't
Yes.
there. Again, now I'm curious. Can this be ever used for epilepsy surgeries?
So yes, so that there is a big subset of functional and psycho surgery cases which can be done using radiosurgery.
Okay.
So before coming to epilepsy, I'll tell you first is trigeminal neuralgia. You know, the pain on
Right.
the face.
Yes.
So there are some cases which are not fit for surgery, who have exhausted all the other options of
Right.
treatment.
Right.
Those are good candidates that can be done by radiosurgery.
Okay.
Then
That is very interesting
yes.
because I have a gripe against trigeminal neuralgia in that so just for people to understand, trigeminal nerve is a nerve running on the face, and some people will have very sharp shooting pains on
Yeah.
their face, and invariably all my trigeminal neuralgia patients would have at some point gone to a dentist
Yes.
and they would have had one or two teeth removed.
Yeah.
And despite removing the teeth, if they haven't had pain relief,
Then they come to
then they come
neurologist.
to the neurologist.
Yes.
So I'm yet to see a trigeminal neuralgia patient with all their teeth
Yeah.
intact.
So for trigeminal neuralgia, if they come to us, first treatment is of course medical. You know that
Right.
we give medicines to them. There are then if the patient is still symptomatic and we see a blood vessel coming close to the nerve,
Yeah.
we explain the patient and give the option of surgery, because that has the maximum chances of improvement over a period of 5 to 10 years. It has
Right.
the best results.
Right.
But then there are some cases who are not fit for surgery, elderly patient, or who have undergone surgery and failed.
Right.
Those are a good subset of patient we can treat by using ZAP.
Right.
And apart from trigeminal neuralgia, ZAP can be used to treat radiosurgery can be used to treat tremors. So we can make lesions in your basal ganglia,
Right.
and we can use treatment for tremors, unilateral tremors, early one-sided predominant Parkinson's disease.
Right.
Then we can do treatment for OCD, obsessive compulsive disorder.
This is fascinating.
Yeah.
Because I don't think I've ever seen an OCD patient getting
So,
surgical
yes.
treatment.
Yeah. So
Is this a new development?
no, we were doing in NIMANS, we were doing a project on OCD where we were doing DBS for
Yes.
OCD. So we had done quite a lot of cases there, and they were improving actually. So radiosurgery can also be done to create a permanent lesion in the areas.
Okay.
So to treat this, and apart from OCD, it has done for chronic pain syndromes. It can also be used for, like we were discussing, it can be used for creating lesions in epilepsy. But it is not as widespread use of radiosurgery as yet.
Right.
But there are a lot of papers which have shown improvements in it. But I have no experience on treating epilepsy with it. But it's a possibility, we can do it.
Yeah, but this is very interesting because it seems like it is opening up a whole new world
Yes,
of possibilities. And as research goes, we
Yeah.
learn more and more about where we can use this. I want to talk to you a little bit about patients who have already undergone surgery. So they've gone through surgery, they've gone through radiotherapy. What does rehabilitation look like for a brain tumor patient?
So generally for brain tumor patients, our rehabilitation, if everything goes well, the patient goes walking home. But it's a big stress for the patient, for the whole family, that you have undergone a tumor patient, especially for tumors which required therapy, radiation therapy after that.
Right.
And in that time, they need a lot of help from our neuropsychologists, because it's draining for them.
Yeah.
And also because of the location of tumor, there can be sometime transient to permanent changes in behavior, in personality, in language areas. Sometimes the tumor which was close to your left side of your brain, which was close to language centers. If you have some speech disorder, you need a speech therapist. We need physiotherapy and rehab people to take care if you have developed some transient or permanent deficits with your locomotor function.
Right.
So yeah, so we need a supportive staff which around a neurosurgeon for cases of brain tumors once we do that.
Right.
And apart from that, we need counseling for the family and for the patient.
Right.
Counseling about how the prognosis of the tumor is going to be, how they're going to take the stress and how they're going to go around the whole therapy, because it's very taxing to undergo radiation therapy, and then sometimes chemotherapy is required. And that is especially true for kids, when children having tumor, the whole family gets impacted by that.
Absolutely. And this is such an important point that you highlighted, because the mental health aspect
Yeah.
of cancer is largely overlooked, because
Yes.
all the focus is on chemo, radio.
Yeah.
But the family, the patient themselves, and
Yeah.
the family is going through so much.
Yeah.
In fact, one of my colleagues was working in a children's hospital in Bombay, and they did a project where the kids who are coming with cancer, what is the impact of that on the siblings?
Yeah.
And
That's a
this is something that most people don't think about, but that sibling is so conflicted, because the parents' entire attention is on the sick kid,
yeah.
and the sibling will feel that they're feeling sad for the patient. At the same time,
They're
they feel
being
that
left
nobody's
out.
looking at
Yeah.
me. It is
Too
so
much stress for
confusing.
such a young age.
Absolutely.
Yeah.
So counseling is so important in such a
Yes.
situation.
So yeah, a lot of hospitals and centers, especially which are dealing with cancer and neurological as well as psychiatric diseases, we have a social worker team which
Right.
takes care of all this thing, which the clinician may not be able to give that much time on these aspects always, because you're more focusing on how to improve the clinical outcomes or the surgical outcomes, and we have a supportive staff which takes care of these things.
Yeah. One question that is very, very important is, can there be anything that people can do to prevent brain tumors?
So this is an interesting question actually, but there are some genetic syndromes where if you their brain, like neurofibromatosis, like Turcot's, MEN, these are syndromes where you have tumors in other part of the body as well. So if those syndromes are running in your family, you can have screenings for early detection. But I'm not sure that there are any things which we can do to prevent brain tumors. But indirectly, how we can affect this is by causing the overall tumor load. The metastasis to the brain from other tumors is a big subset of tumors that we see in daily practice. So if suppose the commonest tumor in the world, lung cancer, reduces, so there can be less mets in the brain.
Right.
So if you can reduce smoking, not get lung cancer. The lifestyle changes can avoid breast cancer or alcohol, like for getting any GI cancers and all those things. So you can reduce metastasis to the brain. So just indirectly, your lifestyle may affect that.
Yes.
But for primary brain tumors, I'm not sure how you can prevent it. There is nothing as such yet. But history of prior radiation, getting radiation before in your lifetime to the brain is a potential
risk factor.
Risk factor.
Got it.
So if you've had radiation in your childhood, you can be a little more careful to get sometimes screening in, but it doesn't work that way.
But it's a very, very interesting point, because while primary brain tumor you may not be able to prevent except for screening and early detection, very important point that you can still take care of your secondary tumors. So metastasis ko tum kam kar sakte ho.
You can you can avoid them reaching brain.
Yes.
So,
and when it comes to brain tumors, I think we should take all the odds that we can get and definitely reduce cancers elsewhere in your body so that you can avoid metastasis to the brain. That's a very good point. Thank you so much, Dr. Gaurav. Now, I want to change the direction of this conversation to truth finding. So there are a lot of myths out there about brain tumors, misunderstandings that people have. So let's take you through some of these myths, and you can break them, or you can say that, yes, this is true. Okay, so in 1 or 2 lines. So this will be more of a quick question and answer. Okay. So the first myth that people have is brain tumor means brain cancer. So is there a difference between the two?
So yes, tumor can be benign and malignant. So more than 50%, almost 50% of the brain tumors are benign. So if treated with surgery, and we can have a good lifestyle, which is as good as having a normal lifestyle. So if we do not get deficits after removing that brain tumor, or we give radiosurgery for those benign tumors, I think the patient can be as good as a normal person.
As a normal person.
But the commonest brain tumor is glioma, and it has 4 stages, and I think stage 3 and 4 are very malignant.
Right.
And those require extra radiation therapy or chemotherapy after surgery.
Right.
But most brain tumors are benign,
Mm.
but it's because they are located in very critical areas and surrounding brain tissue is important. That's why the treatment is little complicated, but
Right.
otherwise, as such, the tumor biology, they are benign.
Just so that people understand, a benign tumor is one that doesn't spread.
A benign tumor is one which does not spread to other areas apart
Right.
from its location,
Right.
but locally it can have a recurrence at the same area if
Right.
it is not removed completely.
And it can increase in
Increase in
size in that
size,
place.
it can
Right.
increase in size and cause mass effect on the normal brain.
Correct.
But malignant tumors, they have more chances of coming back and coming back at different location from
Right.
the evolved areas.
And can malignant tumors also spread outside the brain and go to other parts of the body?
The malignant tumors, see, brain does not have lymphatics, so the exit of tumors from the brain is not there how it is from other part of the body. But still, there are case reports of these tumors spreading outside of the brain, or even some benign tumors, they can erode through the bone and come out outside of the skull. So that can happen, but it does not usually go to other places in the body.
Understood. Okay. There's myth number 2, which is that all brain tumors exhibit the same signs and symptoms in all the patients.
So as we discussed, like every part of the brain has its own special function. So the tumor in some certain areas may present, like in frontal lobe, may come with cognitive disturbances, behavior and memory disturbances. If that is in temporal lobe, it can present with seizures, or it can have working memory deficits. And if it is in occipital lobe, where you can have visual dysfunction. If it is in the brain stem, you may have cranial nerve function, like we discussed. You have hearing, vision, or you have swallowing, speech. All those areas can be affected. But commonly, brain tumors present with headache and vomiting. But then, most depending on the location of the tumor, they may have a varied presentation.
Right. So very similar to stroke patients, where
Yes.
where the stroke is
Yes,
happening will decide the symptoms.
Yeah. So we can localize the tumor depending on patient symptoms.
On the
So
symptoms.
it comes in the clinic and we presented with some suppose weakness of one half of the body,
Right.
and some history of seizure, so we can know that it's in close to the motor strip.
Right. Very important point. So myth number 3 is only adults can get brain tumors.
No, pediatric brain tumors are one of the most common cancers in children. I think after blood cancer, they're the second most common
wow.
tumors, and the most common solid tumors of the brain of children.
Okay.
So they have their own common tumors, which are medulloblastoma, ependymoma, and germ cell tumors in children.
Right.
They're very, very common, and I think almost 1/5 to 1/4 of all the tumor patients are pediatric patients, and it's a big burden on the society, pediatric brain tumors.
So in a growing child, your brain is anyway super active. There are more synaptogenesis happening and all of those things happening. So is that one of the reasons why children have more brain tumors?
They not have more brain tumors as compared to adult, but if you compare all the tumors that the children have, the brain tumors are comparatively more as compared to other parts of the body. Say for adults, you have more chances of getting a lung cancer or a breast cancer or a prostate cancer, but in children, brain tumors are pretty common compared to other parts of the body.
Understood. A very common myth, which is not just for brain tumors but overall for tumors or cancer, is that using mobile phones can increase the chance of cancer. Is there any truth to this?
So it's constantly been studied a lot now for last 20 years or so about the mobile exposure and cancers. Until now, there is no direct evidence that using mobile increases your chances of getting brain cancer. But it causes a lot of other problems. It causes, if you're all the time glued to the mobile, you may have some other problems otherwise, but not brain cancers.
That's an important point. As yet.
Yeah, we may know later. It's after some years.
Fair enough. But what your point is, mobile phones can still cause lifestyle problems.
Yes.
And that in turn can lead to other issues. Yeah, that's an important point. But just on this point of radiation, how much radiation is too much radiation? Because people are also worried about radiation from not just natural radiation, but radiation from CT scan, from X-rays. Even I was reading a Reddit article about radiation from microwaves. So these are all things that people are worried about.
No. So I think the people who are exposed to radiation on daily basis for occupational purposes, especially some field doctors who are doing angiography in DSA, cardiologists who are increased risk of getting radiation-induced problems, our radiation therapists, radiographers,
X-ray technicians.
X-ray technicians.
Right.
Those are the people who get constantly exposed to radiation, or if you have had a radiation therapy for some other treatment. So those are the things where you increase your chances of getting cancer. But suppose you are doing a transatlantic flight, it's not causing that much radiation to you. Your if you get some diagnostic test, it is not that significant. And other forms of radiation to normal people in the background radiation is not as much as causing any cancer to you.
Understood. I think that's a big relief. There is a myth, or there's a feeling in the public that if you have frequent headaches, then you probably have a brain tumor. Like I said, a lot of patients will come saying that मुझे tumor हुआ ऐसा लग रहा है. So while we do reassure them, isn't that also partly true that they technically could have?
So as you are a neurologist, you may know headache is like multifactorial. Your migraines, cluster headache, so many things are there. So, but the headache which is related with tumor, as I told you, we have some red flag signs. So it is progressive, including most of your brain, whole brain. It is giving you early morning headache with nausea, with vomiting. You have blurring of vision or giddiness, or you get some sort of neurodeficit, which is involving some, weakness of some area, or some cranial nerve disorders. Those cases you have to immediately undergo a CT scan or an MRI to make sure that something is not wrong in your brain.
Understood.
And the other red flag sign is your headache is not improving with your treatment, or there is a new onset headache which has got a significantly, or your headache has got a new characteristic where it was mild before and now it has become severe. I think that is the time when you should take a scan for the patient.
Also, one more thing I would add is, if you've never had a headache before and you are of an older age group, say after 50 or 60, and you've never had migraine before, a new onset headache in an older person should definitely be looked into. Okay, the final myth, which is that once you are treated and the doctor says, okay, you're cured, brain tumor will not come back.
So yes, as we were discussing, gliomas, those are one of the commonest tumors. They are likely to come back if they are high grade. You have to, so we put the patient on follow-up scans. We make sure that they do scan after, say, 6 months or 1 year time. And even other tumors, benign tumors, if we have some small residue left behind, those cases are likely to recur again. So you have to be constantly in touch with your consultant of neurosurgeon or primary treating physician. And if there are some benign residual tumors which are critically located close to some important areas of the brain, we can always do radiosurgery for those lesions, or other malignant tumors, we can give radiotherapy for them. So you have to be on a constant follow-up so that you does not come up with a sudden surprise.
Yeah, absolutely. This is something that you have to be vigilant about, and
you have to convey to the patient that you need to be on regular follow-up.
Absolutely. I think that about completes our entire understanding of brain tumors. I hope that everyone watching this would have gotten a much better idea, both about what brain tumors are, what are the main features that patients can come with, what are the red flags they should remember, and if they are diagnosed with brain tumor, unfortunately, then there are treatment options available, more than ever before. So there is a ray of hope even in such a situation. Dr. Gaurav, thank you so much for joining in.
It was a pleasure being here. Thank you so much.
Absolutely.
So today is also World Brain Tumor Day, June 8th, and it's a good time that we had this conversation.
Absolutely. Let's spread awareness about this topic to more and more people. And I'll see you guys in the next video. Take care.